built a presentation that is actually probably at least a day or 2 days worth of stuff. So, and we only have 2 hours. So, but the good news is that you have it all, and it'll help you move through it and digest it slowly, because it's a like with from the introduction I got, I understand, and from the past cohort that visited, there was a lot of questions that they had about vision, and it's quite new, and how to try to sorry, try to um, figure out how it kind of plays into people's rehabilitation and how important it is. So we're going to do it in certain ways. It's best to be interactive. So there are things I'm going to show you how to do. And then I do want you to try to practice it later on after the presentation. Okay, so I already know that we probably won't get through all of the information that's in the slides, but I think that the information for you to be able to use for and understand later. Okay, so what we want to do is we want to look at the person as a whole, right? So it's like, as therapists and other health professionals, we kind of just zone into like what we do and how we can affect that. But we have to know that our vision is so important. It gathers the information that we need to interact with others, with the environment, and 80% of it is due to how we perceive, learn, and use our cognition through vision. So we're going to use this like model of triangle of the Mary Warren visual hierarchy. And so the very basis is ocular motor control, field of visions, and visual acuity. So visual acuity is basically something that we're not going to cover because it's not really neurological, and it's more to do with the structure of the eye. Field of vision is a bit of structure of the eye. If there's damage in the eye, you can lose some vision, but also has some neurological impacts. And then the ocular motor control is what we're going to be learning for the first part of how to assess it, and then what are some treatment options. And then with that basis, then we have to have that in order to be able to use things like attention and having scanning and recognizing and higher executive controls. So the first thing is that we have two main visual systems. We have the what is it and the where is it, right? So the central focal vision and the peripheral and ambient vision. So central is what you're looking at. Peripheral is what is around what you're looking at, right? So central is what are you identifying? So it's like you're seeing a bird, and then what is around the bird is your peripheral vision, right? Trees, sky, sitting on a branch. And so the central vision is identifies the features of what is the details when things are static, and peripheral is more dynamic. And then you also can look at how your central vision kind of degrades at night time because it needs more light. So it also is more cone dependent, so more color dependent. And our peripheral vision is more activates when there's like, it detects like changes in directions and speeds. And then your central vision needs to work with your peripheral vision, but it can work in isolation, while your peripheral vision needs to work with other sensories like your smell, your taste, your sound, your touch, to integrate that information. Okay, and so I kind of talked about this already. And so it's like the example is your friend walks up to you, you can see them, that's your central vision. You're able to know their position, body language, space around them, and that's your peripheral vision. And so that helps you then be able to interact with your friend, right? And so unfortunately, with some, not just stroke, but any kind of neurological uh, disease that impairs vision, sometimes those two visions don't work together, right? They should seamlessly work together. And either what can happen is that when people have trouble trying to see, like I read some of the questions about like double vision, right? They work so hard to try to see or one image or trying to focus or what they're seeing. And then their peripheral vision just turns out. So it's almost like they have tunnel vision, right? And though, and then that can also happen the vice versa. Someone could be, you know, noticing something in their peripheral vision up here. And then what happens is that they don't notice what's right in front of their face. So they might walk into an object. Okay, so things like why is it important for looking at vision for stroke and for all neurological um, but in particular I noticed this is a nice study that shows that there's a high fatigue rate with people who have visual who report that they have visual issues, right? And so this study basically says if we do some evaluation and visual rehabilitation, then that's going to help have people be able to reduce their fatigue, right? And so we know this because our visual system is one of those systems, unless you're born with a faulty visual system, like having a congenital issue, uh, we it uses no energy at all, right? Using our visual system is being able to use it with having no energy being taxed on our system. And so when you have something like a neurological deficit that taxes that ability, then that is where it can cause a lot of fatigue, right? Because your brain and your body and your energy levels aren't used to using that as a reserve. So the other things that we want to look at is just things to think about. So classically, when you think about any kind of like brain injury or stroke and you see occipital, you're like, okay, definitely the vision has been impaired. But I want you to think about this as well, that other parts of the brain do influence how we collect the vision. So parietal lobes, right? They have a role in visual spatial cognition for depth perception, navigation, and movement, right? And then the temporal lobe has things for assigns memory and meaning for the images that we see. The frontal lobe receives the information from the the temporal, the occipital, and the parietal, and that again organizes into conscious perception of the location of visual objects. And that's just actually a study that came out, I think, like just late last year that was um, found that. And so the cerebellum, you see a stroke or brain injury cerebellum, you'll probably notice people who have problems tracking their eyes, which is smooth pursuits. They're hard to maintain their gaze, so that's fixation. And we'll go through all these terms and how to treat them as we go along. Steady holding gaze and accuracy of saccade. So basically targeting, right? That's what you'll see. And in the midbrain, it controls our vertical movement, eye movement, and our pons controls the movement of our horizontal. And so I'm not going to go through all these, but this is also something to think about. It's just different areas of the thalamic and how, since our thalamus is the sensory relay station, um, any issue with any of these areas in the thalamus can cause some of these visual issues. So other things that you can see with a stroke or a brain injury are cranial palsies, right? And so cranial 3 nerve, right? You can either have a presentation of all of these 3 of down, out, or drooping in eyelid or dilated pupil, right? So any of these palsies that we're going to show you are going to instantly cause double vision or diplopia. Cranial nerve 4, right? So having trouble rotating the eye down and in, compensating for vertical, double vision. So what they're going to do is they're going to have someone that will typically be tilting their head. And as they tilt their head, what happens is that they're able to then get rid of that double vision, right? So it is important to also look at like head alignment, eye alignment, which we're going to talk about later. Cranial nerve 6 palsy, trouble with eye turning outward and resulting in double vision by side. The further the object, the person is looking more towards more distance between the images. So nystagmus is also something else that you've probably seen someone's eye just kind of like do boop, 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 or right. So it's an involuntary rhythmic movement of the eye, right? And it should be up, down, or rotational. The consequence of this is that the person feels like they're constantly moving, they feel unsteady, they feel nauseous, right? Because the visual movement, what they feel like is that they're moving, even though their eye is moving and their environment around them is moving, right? And so we're going to talk about the things that you as a therapist cannot do for this, and things that you can't do. So this is just a nice kind of general outline of the visual field cut areas of where they would be, and how they would look like for each of the areas. So we're more concerned where it starts to be around fore and back, right? Just because of the optic radiations and the visual cortex. And so these are things that you'll normally see with a stroke and brain injury. People have asymmetrical pupils. They're unable to see clear at any distances, which is a cognitive insufficiency. They'll have double vision or inconvergence display, so eye teaming, not being able to, eyes are not able to team up. They're having trouble with pursuits, which is tracking, having trouble with saccades, which is controlled targeting, ocular motility, which is being able to look in all directions. You'll see they might have nystagmus, stereopsis issues, fixation. And then we go higher up to things like overstimulation with visual environments, light sensitivity, color blindness, perceptual issues, visual neglect, and agnosia. Okay, so because I wanted to make sure that we kind of picked through all of the neurological diseases as much as possible, there is things for Parkinson's that you would want to take note of. So there is going to be some ocular motility issues, saccadic dysfunction, which is actually a hallmark of Parkinson's disease. Pursuits dysfunction, convergence insufficiency, central peripheral integration, so the two visual systems we talked about, I just talked about before. Blepharospasm, which is when people can't open their eyes, and then their pupils are really reactive, and they may have dry eye due to decreased blinking, which is a part of Parkinson's. Other things higher up, color perception will be decreased, contrast sensitivity, visual perceptual issues, motor perceptual issues, visual hallucinations, facial recognitions like agnosia. And so things like atypical Parkinson's, so MSA, so same thing, can't open their eyes. And so also saccadic issues. So it's having this involuntary saccadic sway and back and forth to the fixation point. So if I was here, the eyes would move across and then back and then down with no slow phase. And then there'll be some hypometria of saccades, so meaning like they are undershooting. Impaired vestibular ocular reflex. So our visual and our vestibular system are very closely tied together. And so meaning that if they turn their head and they try to look at something straight ahead, the thing ahead of them is moving. They can't keep it still, or it makes them really dizzy. Some nystagmus, blurry vision, mild vertical supranuclear gaze palsy, and then impaired pursuits, smooth pursuit. Okay, and so PSP, right? So classically with PSP, it's going to be, the person is going to have problems looking down and looking up when you ask them to do that. That's usually one of the first things that we'll see. I have actually had people who came to me diagnosed with Parkinson's. I did a screen and they couldn't move their eyes up or down. And then I also asked them about if they are falling a lot and if they're falling backwards. And typically if they're falling backwards, that's when I can inform the doctor like, oh, I think this may be some PSP. And so it can help. It can help your team know what to look for if you're doing a good thorough vision screen. So again, trouble opening their eyes, right? Apraxia of eye opening. So that's a little bit different where it's like they can't close their eye. Prolonged or infrequent blinking. Slow saccadic eye movement involving targeting, so meaning like very slow movements to the target and then undershooting as well. And so another thing is that when they're trying to target, what happens is that you should directly go to one point, to the point in a direct line. What can happen with people with PSP is that they do this arching or they have a different pathway to the target. Cortical basal degeneration, right? And so say if someone who has cortical basal degeneration and it's this hand. So if you were to try to have them target over to the side that they have that's more affected, what will happen is that they can't move towards it as quickly. They can't target. Their tracking is impaired, and visual spatial dysfunction is seen very much here, especially to do with objects and what to do with them, right? Okay, and then so things for MS, right? MS actually can be just like a stroke or TBI when it comes to, depending where the lesions are, right? In the sense of like damage. But typically, so typically there is that like optic neuritis where there's that inflammation of the optic nerve, and then the person will see gray, and most of the time they are able to regain. Sometimes they cannot. Uh, and so there's also some peripheral vision loss. And it's, again, so less obvious unless they're like they can be bumping into things, right? Things that is actually characteristic for MS is oscilloscopia, which is it feels like the world is moving. And it's usually when it's happening, there's some lesion in the vestibular system, visual or vestibular system, so brainstem, cerebellum. And then, so the difference between nystagmus and oscilloscopia is that nystagmus has a slowing point and it goes fast. It slows fast, slow, fast. Well, oscilloscopia is constant. It's a constant speed. Okay, and then so also diplopia can be one of the things that you can see, and it's usually at the brainstem or the cerebellum. You get those cranial nerve issues as well. And then so things like Alzheimer's, so loss of visual acuity, defects of fixation, smooth pursuits, stereopsis, which is 3D, when we'll talk about that, saccadic eye movements, changes in contrast sensitivity, visual spatial function issues, right? Things like color, depth perception, perception movements are impaired. Problematic movements, perceptions make the environment feel like they're flat. So it's like a whole bunch of flat, not 3D, can occur. And it's just like, instead of what we see as one smooth movement or continuous movement, they can see things like picture by picture by picture, like just a bunch of pictures. Visual memory, agnosia, and visual hallucinations. So things with Lewy body dementia, same kind of things. But the main thing that's same kind of things as the Alzheimer's, but the main thing that is different is that there's pareidolias. And so basically those are visual hallucinations of meaningful objects that appear from a big ambiguous forms within scenes. So for example, like if there is a coat rack, I had a patient who has a coat rack in their house. And every time he sees the coat rack, he thinks it's Captain Jack Sparrow. And he knows it, but that's what he sees. So that's an example of one. Versus hallucinations are things like usually things out of nowhere that have no organic base to it. So things like people will say, oh, I see cats walking, or I see animals, other animals, or bugs. That would be more of a visual hallucination. Other things would be, again, the hard to open your eyes, and then also decrease blinking. So frontal temporal dementia, right? So fixation and saccades, right, are part of the issue. So again, we talked about before, I said, the temporal and the frontal lobe do have a play in vision. And so they think it's because it's the inhibitory control and executive dysfunction that causes the inability to keep someone's eyes steady, right? So fixated on something and being able to target, move your eyes and stop at will. Visual spatial dysfunctions and also visual hallucinations. Okay, so Huntington's disease, right? So with Huntington disease, there's oculomotor apraxia. So if you've ever had someone with Huntington's and they're trying to move you ask them try to move their eyes, they'll tend to move their head first before they move their eyes, right? So it's like a kickstart for them to move their eyes. Slow saccades, smaller amplitude of eye movement, broken pursuits, meaning they follow it and they stop and then they'll catch up and then follow it again. Abnormal fixation, problems with convergence, decreased blink rate, again, trouble opening your eyes, trouble closing and opening eyes, because they have apraxia of the eyelid, visual spatial, visual scanning, visual attention issues. And so probably they have a lot of issues with facial emotion recognition, visual object perceptions, and visual spatial processing. Okay, so now that I kind of gave you this kind of brief overview, what do we do first? Well, with the cranial nerve palsies, what I typically do is I definitely wanted them to see a neuro ophthalmologist or a neuro optometrist to kind of see if we can get their alignment better so then they can have a better ability with a prism. And so what a prism basically is it is a lens that's thicker on one end and thinner on the other end, and it redirects your eye into a direction of where you want it to be. So the thicker part could be on the outside, can be on the top, can be on the bottom, can be on the inside. And so wherever that thicker side is, so say if it's on the outside here and the thinner side was here, my eye would hit the lens and then it would be forced to move. Instead of going straight, it would be forced to move inward, right? So wherever the thicker side, the vision is going away from the thicker side, right? And so, and then also if the, diplopia from the cranial nerve palsy is too great, then sometimes ocular alignment surgery is necessary. I have had that. Or people where a prism doesn't work, ocular alignment surgery doesn't work. I mean, does work, and then I treat them. And then we'll also talk about later on what we can do in the meantime for double vision and diplopia when they are, say, waiting for their surgery or waiting for their lens. Okay, and so field cut, same thing. I would send them to a ophthalmologist, neuro-optometrist, for peripheral prisms for visual field expansion, right? And so what that is again, they're prisms, they're different prisms, but this time they expand your field of vision, and they can expand their field of vision up to 10%. But definitely as therapists, we can still see people during this time because whatever field of vision they have, we want to make sure that their ocular motor skills are still working quite well in those. So being able to maximize the ability of what they have, collecting, making sure that they're maximizing their ability to collect the information for their interaction with the world. And so things like nystagmus. So nystagmus, again, this is definitely something you would have to have your neuro-ophthalmology do. Things like gabapentin, baclofen, memantamine, clozazepine usually are for things like more like a downbeat nystagmus. So it's like this. You see eyes do like this. And then baclofen is for alternating nystagmus. So sometimes you'll see like, and then gabapentin is more for this type of like swinging, more like an oscillation, right? If they're just doing, or usually it just goes in one direction constantly. Photophobia, there is something called light therapy. I don't think you have it there in Thailand, but here we have it. It is within the scope of practice of the neuro-optometrists. And so basically what it is that unfortunately after any kind of damage to the brain neurologically, sometimes people are very light sensitive. And so what can happen is that because of that light sensitivity, it can drain your system. Because when you think about your pupils are connected to your autonomic system, right? Your fight or flight. And so a lot of people will feel drained from it because part of it is that their pupils aren't able to contract enough to keep the light out. And so if they're unable to do that and they let too much light in, that can overwhelm your system and make you more fatigued. Also, that your brain is trying to tell your pupil to contract enough, and not doing it takes a lot of energy. But we also can do something in the meantime as well, and we'll go through it after. So visual midline shift. So that is where, again, from neurooptometry, you'll have, you need yoked prisms to do that. And then once you get the yoked prisms in, we could do some treatment. And it's also in this presentation. Okay, so these are the things that you would commonly see as ocular visual defects, right? So these are the things that you would see on the common defects. But then, you know, a lot of people, when they say words like, oh, my vision is blurry, or I have eye strain, I'm dizzy, you know, I can't stand the light, I feel really emotional, I get overwhelmed in busy environments, headaches, nausea, those are actually signs of ocular motor dysfunction. So now into the evaluation, right? So this is going to be what you would need to do to basically see how someone's ocular motor skills are, and then how to treat them. Okay, so for the pupils, right, you want to check this symmetry, size, and contraction, right? So this is my trusty pen light. And so what's great about this is that it tells me when I look, I just tell someone, look straight ahead. And I have them look straight ahead. And then I hold this up and I can see, you know, are their pupils, first of all, symmetrical? If they're asymmetrical, that is always a sign of a neurological issue going on. But then this tells me if they're like dilated or contracted, right? And so what you would do is you tell the person, you know, look straight ahead. And then as you're, you know, looking straight ahead, you're coming in from the side and you're going to shine a light directly like this for 10 seconds. And while you're doing that, you're observing what the pupil is doing, right? So you're seeing if the pupil is contracting and staying contract, or contracting and then slowly fluctuating, or not contracting at all, or contracting and dilating, right? That can give us an idea of, you know, if the if they're light sensitive, B, if the light is contributing to their fatigue. Okay. So what are some of the things that I would do for treatment wise? So what used to be the old school thing is that we'd say, okay, don't, avoid lights, stay in the dark, make sure you feel good. And so we don't do that anymore because the research shows is that we have to build a tolerance. If we are constantly avoiding the light, that actually makes the photophobia worse. So I always tell people, try to tolerate the light as much as you can until you start feeling 4 out of 10 symptoms. And then you can use, say, like a brimmed hat or sunglasses or, an eye mask before they start. Because if they just continue to do sunglasses or being in a dark room, light avoidance, it makes it worse, right? And so the thing that we can do, we talked about light therapy for light sensitivity. So this is kind of like an old school way of uh, treating photophobia that can basically, you're exposing the pupil to the light in different directions. So what you do is you tell people to cover one eye, and you're going to do it for both eyes. And you take a pen light and you tell them again to look straight ahead, and you shine a light at a 45-degree angle for 15 seconds from below, from the side, from above, from the side, and then straight ahead. And then you switch eyes. And so I tell people to like breathe, because sometimes what can happen is that they're holding their breath because they're sometimes anticipatory of pain because light has been so painful. So they tend to hold their breath because they feel like and they don't even know it. So just, I tell them to try to do it before bedtime. Most of the time, most of the reason why is because people it tends to give them symptoms and then they could just go to sleep. But on the rare occasion, people do get overstimulated, and then they can't sleep. So then I tell people like, do it some other time. And if they just can't handle it, I just tell them to not do it. And then we try to like habituate in a different way. Oh, but I also wanted to mention is that they can, even though you're doing all different directions, they can take a break between directions, um, as long as they need to. Uh, so that's not a requirement. Okay, so looking at the eyelids. So are they having droopy lids? Also, are they having trouble opening their lids? Are they having trouble closing their lids? Right? Because this is important because, you know, I know I read the questions. There was a couple questions, 3 questions I was asked, given before the presentation. One was, the effects of rehabilitation, vision rehabilitation, like long-term, short-term. The other one is how to help someone who is walking with diplopia. And then I think another one was just like diplopia in general. How do you treat diplopia in general? And we will cover that. But, and so part of that is your eyelids actually can make a difference if you have what's called monocular double vision, right? Monocular diplopia. And I will go into detail about the difference between binocular and monocular. And so what you would do is just refer to also plastics for lid lifting surgery. And if it is something like in the case of Parkinson's or Huntington's, sometimes contacting your doctor to see if there's any medications that might be able to help with the blepharism or the apraxia of eyelid movement, can also be a way to kind of help your patient. Okay, so head positioning, right? So we're looking at the person's head and eyes. So again, if you see someone like this, right, they might be compensating for some kind of ocular issue, most likely double vision. So, you know, before you correct it, it's good to know. So looking at head position, looking at how the eyes are. So eyes, so we use the terms of isotropia, which is in, exo, out, hyper, up, hypo, down, right? And so those are the things that we want to look for. And then what I like to do is I observe it with the way their head is, and then I like to correct their head and then kind of re-look at it again just to see if that made any differences. Okay, another formal way, usually I have a paddle, but again, I'm at home, is that you just have the person look straight ahead. And if you had a paddle, you cover up one eye and you're looking at the eye that's exposed to see if the eye moves, right? So you'd have them look straight ahead, cover just for a couple seconds, and then you're looking to see if it moves, right? And so that's where you can see if there's iso, exo, hyper, hypo. Okay, that's the same thing. Okay, so visual midline shift, right? So let me get a pencil. Okay, so usually a neuro-optometrist is going to be best at assessing this, but as therapists, we can still assess this quite easily. So you give a pencil, right? Tell them to hold a pencil and tell them to track it towards their eyes. And if you see someone that does this, then they have that's a positive visual midline shift, right? And so another thing that could be indicative of a visual midnight shift is that I've had patients in my office and I have them try to read something and I give it to them and then they put it off to the side and then I ask them, is that center to you? And they say yes. And then when I shift it back to actually their center, they feel like it's really off. So that's also something that you would see. Okay, so treatment of a visual midlight shift, right, is basically trying to help them recalibrate. Sometimes I have a mirror for them to help them know where things are in the center, or have this awareness of like trying to make sure where things are in the center of them. Also, you start doing a lot of vision and balance vestibular exercises after they get their yoked prisms, because that's going to have the most impact to change. Okay, so when we're looking for ocular motility, right, what I tell people to do is I tell them to keep their head still, and then I have them shift their eyes up, down, left, right, corners, right? And so what you're doing here is you're looking at how they're moving their eyes, if there's any restrictions. This is a great quick test for the cranial nerve 3, 4, and 6, right? Also for the PSP, which we talked about before, it's like, can they do up gaze, down gaze, right? So this is something that can be helpful, especially if they have symptoms. So a lot of people will say like, oh, I feel dizzy after, which means like anytime they're moving their eyes, they're dizzy, right? And so And them being dizzy is also like taking away their ability to do things like walk or be able to reach for things properly, their energy level. Okay, so how to treat this is you would do what's called yoga eye stretches. So basically, it's kind of the same thing that I had doing in the assessment, but this time I have them just move their eyes up and actually want you to do this right now because it actually feels pretty good. Uh, um, so I want you to keep your head still and then look up, take an inhale through your nose, hold it for 3 seconds, and then exhale to center. And then look down, inhale, hold 3 seconds, exhale to center. Look to the left, inhale, hold for 3 seconds, exhale to center. Look to the right, inhale, exhale, center. Look to the upper right, inhale, exhale, center. Look to the upper left, inhale, exhale, center. Look to the lower right, inhale, exhale, center. And look to the lower left. Inhale, exhale, center. And so what we want to do is we want to try to get the ocular muscles working as well. So when people have any kind of neurological issue that impairs your vision, they tend not to move their eyes that much because it causes either dizziness or nausea or headache or fatigue, or just they just avoid it. And so by avoiding something, our ocular muscles are just like any other muscle, right? If they're not used in their full range of motion, then that's when things like eye strain or stiffness can come. And so I always tell them to just go to as far as they can go. And then the breathing is helpful because it also helps relax them by when they're moving their eyes. The face clock stretch is just an advanced one where you'd be looking at, you think about a face of a clock and then you shift your eyes to the 1, 2, 3, 4, 5, always going back to center. Okay. So some of the compensation things for the head movement, not for eyes not being able to look down, which is important for things like eating food or looking down to do any kind of tabletop activity. Again, there's like bending your neck, using your neck, but typically with stuff like PSP, stiffness in neck will just prevent you from bending your neck. So things like this, prism mirror glasses, which basically are mirrors. If you can see at the bottom, that picture of the glasses, so you can see what's down here without moving your head. Pursuits. So what you're going to do is pursuits is basically tracking, right? Smooth pursuits. So I tell people, okay, look at this tip. Okay, keep your head still. And so what you're gonna do is you're gonna watch them as you do an H pattern, right? An X pattern, and an O pattern, clockwise and counterclockwise. And so things that we want to see is eyes moving together, moving smoothly together, not lagging. Also, you may see things like freezing, jumping, mild jumping. And then also people just saying, oh, that really made me nauseous, or I feel really dizzy, or have a headache. I feel disoriented. So I will say subjective reports of how someone feels is just as important than the objective things that you're seeing, because those are the things that are making them feel this way. And then if they're feeling this way, they're less likely to participate in rehab overall. So again, so some of the things that you can do in the sense of treatment is I usually have like say if there's just a letter on a stick, right? And then I'd have them track this letter, right? Or track a coin, right? And so the goal is to go as fast as you can, but make sure that they are still seeing whatever they're looking at sharp and clear. If it's too fast and it's blurry, then you have to slow down and get the brain's attention, because we want to get the eyes moving together. And so I think one of the things that the first question of like rehabilitation for vision, think of vision like any other body part, right? It has the potential to have a certain level of rehabilitation, depending on how much damage was caused. If there's enough neuroplasticity, enough area to drive the neuroplasticity, then some people can get full recovery vision wise. But it also depends, because the occipital lobe is so particular in certain things, as it is it's in the presentation, that if certain areas of the occipital lobe are damaged, then they will not regain that function. But it's just like rehabbing an arm, rehabbing a leg, vision is. So you do it, you do it, you do it, and hopefully you drive enough plasticity that then you can upgrade or discharge the exercise. So things for like slower or reading pursuits, tracking, right? Sometimes I just say, okay, pick a basic shape and pretend that there's a little bug crawling across this at a bug speed, right? And then there's also like with the iPhone, there's a timer, and if you set it for 2 minutes, it can go, you can have the person track something if they feel like they can't do the invisible tracking. Anything that's fast, right? You could have them track anything that swings. And so that is to kind of, you're upgrading depending on the needs and for that person. So being able to track smoothly, right? This one in particular, you're laying down and they're hanging something above, and they go up and down for 10 seconds, side to side, side to side, 10 seconds, diagonal, 10 seconds, and diagonal, 10 seconds, and then circles. Okay. And so that's how you would do for faster pursuits. Okay. So CCATs. So targeting, basically controlled targeting, right? So I just usually say, here are two pens, look back and forth between these two tips as fast as you can without moving your head. So I have them do this, right? So they do 10 reps of this, and then I have them do this, 10 reps of this, 10 reps of this, and then 10 reps of this, right? And so, so this is where you can look at if they're undershooting, overshooting, if they're delaying in their target, delaying in like leaving the target, also the pathway that they're going. So this can help with figuring out what exercises can help. We have this, and I put this in your handouts, presentation handouts. And it's a standardized adult developmental eye movement test. It's standardized, and so what happens is that there is a vertical sheet, two vertical sheets, and one horizontal sheet, and you have them read them out, you time them, and then you divide it to get their ratio. And there's also standard norms for it. And so treatment-wise, we could a, a small chart like this, and a big chart like this. Okay. And so what you're doing is you can have them look back and forth. So you have the person holding the small chart in their hand, and then the big chart is on the wall. And so what they're doing is they're looking, reading here, here, and then the small chart continuing. So it could be like this. So O, E, and then they would continue here with Y, Z, and then they'd look back up to do E, T, right? And so things can be adapted language-wise. If they have aphasia, you can use arrows. You can use different movements too if they can't really speak. So this is what we are looking for. So when it comes to things like saccades, we really want this pattern of trying to hear, right? So because the thing is that if someone, sorry? So if someone tries to, if someone's trying to say they want to do this, but they do 1, 2, N, D, 1, 2, right? Or 1, 2, A, 1, 2, E. That's not what we want. That's cheating. What we want is we want people to try this pattern, which is on the screen right now, because that's how they're going to gain functional control of their targeting eyes. I'd rather people try and mess up, because then at least they're trying and then they'll learn. Okay. So another treatment is these letter sticks, right? And so what you would do is kind of same thing. You'd have them have their head still, move their eyes, top letter here, top letter here, second letter here, second letter here, third, third, fourth, fourth, all the way down, and then do it here. Sorry. And then do it like this, and then do it like this, and then do it like this, right? So what you want is to try to get their eyes to move exactly to the letter and saying the letter as they see it at the same time. And so you have actually a copy in your files that I've sent you of a bunch of these, all different levels. There's 1, 2, 3 books of these. And so you have a copy of all of a bit of each, so you'll know. So basically, this one's important for reading. And if you can see that there's a little underline, and those underlines are what people are reading. So they're not just reading across, they're stopping. So 8, 7, 9, 3, right? So those are the things that would be, they would stop at, right? And so what's nice about this is it can be adapted for any language direction. So I've had people who are, you know, read it up and down because that's what their language is, or they read it instead of right to left, left to right, right? Um, so it's one of those things that can be adapted in many ways. Okay, so we're coming to accommodation. So accommodation is the ability of each eye alone to see clear, right? So um, it is an essential building block for eye teaming, for convergence. Um, I like to think of it like a a three-legged race, right? So if two people are individually nice and strong and they work together, they can learn to work together quicker. But if like one person has like kind of a hurt knee matched up with someone who is like no injury, it's going to be harder for them to learn to work together. Or the person who is stronger might be carrying um, uh, more responsibility than the one that has the hurt knee. Um, so basically, we need to have each eye to be able to see clearly at any distance, right? So, and this happens when our eyes, when we look far away, they naturally relax. And when we look up close, they contract. But our eyes are actually instantly clear, better than a phone camera. So when you think about it, like you open up your phone camera, and there's a little bit of blurriness and then it clears up. Our eyes should never do that. Our eyes should be clear instantly. Okay. And so there's a couple ways of doing it, right? So you can do it this way, right? The tracking, right? And so you are watching the person's eyes, uh, the people kind of like contract and relax, right? And then they can also tell you. Um, Another quick way that I can have people do is I have these two charts again to assess, this small one and this one. So I tell them this one's hanging up on the wall and this one's in their hand. And I tell them without moving their head, covering one eye, to look at any letter, it doesn't matter. So I get them to look at any letter they pick on either the wall or in their hand, and I have them look back and forth between them without moving their head. And I ask them if it's instantly clear, right? And most of the time people will be able to say, yeah, it's no, there's a little bit of a lag when I'm looking far away. It's not as clear, and then it clears up. And while they're doing that, I'm also looking at their pupils. I'm looking at how, because you can see their eyes contract when they look up close and relax when they look far away. And so the other thing that is you want to be looking, or what's challenging about this is what is accommodation versus what is acuity. And so sometimes people, like here in America, I will say like not a lot of people get their eyes checked. And sometimes they haven't had an eye exam in years. So it's hard for us to figure out sometimes if something is acuity or accommodation. Um, Most of the time, if they have perfect eyesight, they can say, oh yeah, this is, you know, I never need glasses before, and now things are blurry. That helps me to know it's more of accommodation. If it's something like, oh, I haven't had my eyes checked in a while, and I do wear glasses, and the glasses weren't working that great before whatever neurological issue, that's where it's kind of iffy, and I don't know if it's going to be more acuity versus accommodation. So what I tell people to do is that if they think about, so they imagine that whatever they're looking at sharpens up a little bit without squinting the eye. Because when people squint their eyes, they are physically compressing and changing their eye shape, which is what helps. Because basically what glasses are to help correct the abnormal shape of your lens to make it a perfect circle. And so if people can look at a letter and imagine it clearing up and getting sharper, even if it's a tiny little bit, then I know it's accommodation. I know that it's their brain not telling their their eyes to contract or relax enough, right? Okay, so accommodation for treatment, what you do is you can just, this one's the easiest one. People do this often. They will, you'll cover one eye, right? Tell them to pick something with a detail up close. Sometimes people, people have their hands with them all the time. So I like the thumbnail, pick something far away that has detail, and then look back and forth between the 2 points and making sure that they're seeing it clear. And before they move to the next, or as clear as they can if they can sharpen it up. Because then you're teaching your brain to tell your eye how to relax when looking far to see clear and contract, right? And then you repeat the same thing on the other eye, right? So accommodations is unique because it's the only ocular exercise that's going to be just each eye alone. All the rest, it can be each eye alone if you have like more significant problems. Like I've had some patients that were like, oh, I have more problems on my right eye. So then I do tend to give them more isolated, vision exercises for their right eye and for both eyes together, just to try to get the one eye to catch up. But accommodations in particular, it has to be done with each eye alone. Another one, and I don't have this to show you, is just basically you get a sticky note in a circle with a bunch of alphabet letters or numbers, whatever you choose, and you have them target back and forth, and then you have a stick, right? So it'd be like a stick like this. They'll be holding the stick up close, and then they're going to be able to see the you're going to still be able to get the far away and the contraction with something a little bit more concrete if someone has problems with the picking the two. Okay, so as again, this near far chart that we talked about already, about you can do this for accommodation, you just change it with one eye. So you do the same thing that you do. Okay, and then, so it's kind of like a bit of the assessment, but this time you're getting the person to do this. So I have this, I'm looking at the top letter, and I'm gonna try to keep it clear as I'm moving in, right? And then close eye, and then I open it up, and I move it out, keep it clear, right? Close eye, go to the second letter, same thing, blurry, open eye, clear, and then you repeat. Okay, so this is in my office. I don't have this object, but you don't really need this. We use this because it is used in research. It's a standard a practice for getting your convergence, right? What's nice about this rule that you see is that it's already marked for you, so you can have it in centimeters, so you don't have to measure it. But before having something like this, like you don't necessarily need this. As you can see, I'm at home. I have a whole bunch of things. I've been just using like paper and a pen. So I'm going to show you how to do kind of the old. So So usually, a 4-point font, right? That's what you would use. But, you could also just use a pen, with pen tip, which is fine, right? And so what you're going to do is you're going to have them look at the pen, right? So you can do it two ways. There's ways where you're controlling it, and there are ways that they're controlling it. And so if they were controlling it, sometimes I say if they're able to hold on to it because their neurological disease doesn't impair them, then I would have them look at it, hold it, and move it in and move it in. And so I'm telling them that I want them to look at this tip and tell me when they see double and to stop, right? I'm also looking at their eyes, and I will see if their eyes are moving together or not. So what's challenging about this is that you have your objective, which is what we're looking at, and then they have the subjective. Because some people will be like, I don't see double at all, right? And so how do we know their breaking point? We know by what we see and how their eyes are behaving. So we want to be able to see that their eyes are moving together and then they're moving apart in rhythm. If we don't see that, if we see something where it's like this, then as soon as we see that deviation, we tell them to stop. We tell them to stop because what we do is we measure from the side to here, and that's their breaking point. And then we tell them to move away. And so we're then looking to see when their eyes start to get in line and move together. And they're telling us, oh, I see one now, right? I'm always going to take what I see first. I'm going to tell them to stop. And then again, you'd measure it from the temple, the side, and that would be their recovery point, right? And then what I like to do is then I take the pen and I just want to see really how their eyes work. So I'll just do this 3 times just to kind of see the rhythm. And what's helpful for that is to see if they're also able to get their eyes to start to team up, right? And so this is important because it's to do with things like the diplopia and double vision, right? So exercises, right? So sometimes just seeing this, like you're saying, oh, I see double. First thing I'm going to do is going to ask they can fuse these things together, right? And we'll talk about this a little bit later. Just the fusing and why that's important is because we want to make sure that people have the ability to move their eyes together and not just let one image disappear. Because if one image just disappears, then what can happen is that means their brain is no longer taking in the information from one eye, right? So basically, even though both eyes are open, their brain is seeing this. Okay. And so sometimes if this is like blurry, when they first look at it, I tell them to, try to get it clear. Top letter, clear, good. Close eyes. Open to the second letter, clear. Then I tell them to close their eyes. Third letter, try to get it clear. They can get it clear. Good, close eyes. And so that's called pencil push-ups, right? And then there's going to be the dynamic pencil push-ups. So when people get better, so they can see this clear, is the moving, right? So it's going to be looking at the top letter, moving it in, blurry, close eyes, same letter, the top letter, clear, 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 close eyes, open to the second letter, bringing it in, clear, 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 close eyes, open to the second letter, which is the same letter, keeping it clear as you move. And then I'd have them repeat that. Okay, so this one is an important one. Let me get the sticky notes. Okay, so this would be what we'd want. Oh, let's see. Okay. So you'd have one sticky note like this, and you have the person, sometimes I just have them use their thumb. And when they're sitting, they're going to close one eye and try to line up this thumb from where they're sitting, like it's in the middle like this. Okay. And so then once it's like that, I have them open both eyes and they look at their thumb. And so when they're looking at their thumb, they see one thumb. So they should be seeing this actually. They should see one thumb. Let's see if I can get this closer. They should see one thumb and two sticky notes when they're looking at the thumb. And then keeping the thumb where they are and the sticky note where it is, they switch. They look at the sticky note. And when they look at the sticky note, it should be one sticky note. Here, I'll go further down, sorry. It should be one sticky note and two thumbs. Okay. And so that is important because that's what eye teaming is. So basically, when we're looking at any central vision, right? And our eyes are converging on a single point, we see one. We see one of that, and everything else in the background is actually double. And so we have another thing called suspension in our brain, which then is implemented, which kind of eliminates the double vision in the background because our brain's like, that's too confusing. But this convergence divergence exercise basically eliminates the suspension. So when they can see something like that, that's how we know their eyes are learning to team up. And it's also important to make sure that is equal spacing away from the sticky notes. The sticky notes are also the same level. The thumbs are also at the same level. If you're having issues, if your patient's having issues, I always tell them, imagine what that looks like. You know what it looks like. So I always show patients, especially with convergence divergence exercises, what it should look like. Because our brain is wired for visual imagery, right? So visual imagery works really well for motor movement. It also can work for vision, because if you can imagine what you want to see, it will fire the same neurological pathways as doing it. So this is actually a really important one. When people are having trouble with convergence, I always start with this one because it's a good one, because it also works on divergence. So sometimes things like if someone has really bad double vision or blurry vision or depth perception, I have them do like something like hand-eye coordination. So a straw and a stick. And if that's too hard, then I upgrade it to something like a tube and a marker. Okay, so the rock string. Rock string is actually very advanced. I had to make one here, so it's not the greatest rock string. There's a picture of it. This. So it works on convergence, fixation, central peripheral integration, anti-suppression, and accommodation. So you could do this with just one eye as well. And so basically, It's like if you are, so this is 3 beads, right? And the way you do it is you hold the string up to your nose and you have all these other beads. You tie it to a doorknob. I usually have this to be about 10, at least 10 feet, as the neurooptometrist says that our eyes technically can converge at least 10 to 12 feet ahead of us. And so I usually make these strings really, really long. They're really easy to make. I just buy some yarn and some wooden beads, round beads, and I just make them because otherwise the Brock string itself for one is $25. And so, so you would hold it up like this to your nose, right? And so as you can see in the picture, if I was looking at the middle bead, right? If I was looking at the middle bead, I should see exactly what's on that. Okay. And then this is a nice kind of picture that helps you understand, because you'll do the Brock string with people and they'll be like, I don't see this X pattern. And so these are kind of the variation things that you will see and what it means, right? If someone's having suppression of the left or right eye. So interestingly enough, the X pattern that you see when you do it, the string closest to you coming to towards your right is actually your left eye suppression, and vice versa. And it's all written down on here, right? And so what can you do? You can use things like if they're having those kind of things that we saw on this page, what you can do is sometimes I have people hold the string and have them like cover one eye as they're holding the string, right? And so they're holding the string, they can cover it. So then we get the eye that's being suppressed looking at the bead. And that what that does is that helps your brain already process what it's looking at. And then, which makes it harder to suppress. So then you slowly reveal your eye to look at the same bead. And what that does sometimes, it helps the ability to see the X pattern. And sometimes it's just a flash, but that's the beginning. That's good. Just because it helps with understanding that your brain needs to integrate these two, the two information, the information coming from your eyes to be able to have depth perception, right? Because eye teaming is part of depth perception. Another thing is that there's like a chart and a mirror, and you would use a mirror to kind of help okay. And then, so anti-suppression, that's the other thing, right? So there's charts like these. I don't know if this is going to work. I was going to try something. I don't know. Yeah, it might work. Okay. So you can see that this is one lens is green, one lens is red, right? And then you have this card like this. And so what it is the design is that the white background letters are for the green and the red background letters are for the red lens. And so it kind of worked. Let's see. So when I do this, you can see all the red background letters, right? See how the white ones disappear? And then when you do this, same thing. All of the red ones disappear, but the white background And so when you're wearing these glasses, it's a way to force your brain to use the information from both eyes because you know that there's a whole chart there. And so by doing that, you can get your brain to make sure and think about, again, using that visual imagery, being like, I know what's supposed to be there. I know there's a letter there. I want to see it. Can get your brain to integrate the information from both eyes. And so another great thing about this, that how I use this, is sometimes people can only see basically the white background or letters or the black or the red background letters. And what can happen is I have them try to read it across, and as they're reading it, they might not see a set. And if I tell them what the letter is or the number, then their brain starts to see it, right? Um, also, this also can help you figure out like if people have central versus peripheral suppression, and then you can use this as a tool to also help overcome that. Okay, so stereopsis is another thing that contributes to our depth perception. So basically what we have is stereo cells in our brain that turns on to tell us, and it's the only thing that turns on to tell us where the depth of an of what sorry, my phone was gonna die. Okay. Okay. Um, and so it shows us uh sorry, my phone is okay. And so what stereopsis is basically this is a great picture of how our eyes work. So if we look from one eye, the tree looks like it's on one side, and we look on the other side eye, the tree looks like it's on the other side. But when we use our eyes together, we actually see the true depth of where it is, right? And so this is really important um, to our field of depth and seeing things in 3D instead of 2D, like a picture. And so the tricky thing is that no one tests this before some neurological issue can happen. So what I tend to do is I ask people, have you had, were you able to see 3D movies in the past? Or 3D images? And some people can tell me yes, some people like, I've never seen it. So um, some people say no, they made me really sick. And so at least I know what their baseline is and if it's something that the neurological thing has impacted. Okay. Things like vectograms and transglyphs, right? These are things that you can use. Vectograms, you can use those like 3D glasses, those black ones you get at the movies. And they are variable, so you can change the distance of the vectogram, right? And they're usually black and gray. I have one in my office that I was going to show you, but I don't have, I'm not there. And then the tranoglyphs are fixed and they're usually red and green. So you use these glasses again. And so you can actually train convergence and divergence with it, with depending on if you want to merge the image or separate the image, right? So something like this. So these are examples of what you would see. But when you put the glasses on, then that is where you can see that they're being able to merge or diverge as you want. Okay, so fixation. Fixation is basically the ability to stare at something without being able to move your eyes away within your control, right? So sometimes I do is I'll have someone stare at something for like 5 seconds, or they use this, right? Where I have them stare each dot for 5 seconds and I watch their eyes. And it's important to watch their eyes. For treatment, what I would normally do is I would do something like this. I would say, okay, I'm going to call this pink. I'm going to call this black. And then I would move, I would call pink, and then I would move this. And I'm watching their eyes to see if they can fixate on the pink. And I'd say black, and then I would do the same thing. And then I'd say pink, and I'm watching their eyes. Okay, 1 minute I would do that. Okay, so basically a functional scan is a combination of our pursuits, which is the tracking, the saccades, which is the targeting, and the fixation, which is what we just did, right? That is the combination. And one of the things we do is we can do what's a standardized alphabet scan. And so what we need to look at is it's a standardized test, and then what they can do is they can cross off the alphabet in sequence. And so what's good about this is that you can see how their eyes are moving, especially if it's something to do with reading, and ask them if their eyes move the same way when they're reading now, right? If they jump all over. So sometimes people will have like, you know, they may have like their eyes here, 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 and then they have to go back to be like, oh, their eyes move like this, or their eyes move down here. So they're shifting. And so this can be helpful in making sure that you can figure out what is their treatment. So things like I Spy, finding matching objects, right? That kind of stuff. Fine. I like this one. You're finding the sentence in this nonsensical paragraph, right? Finding like certain letters in a paragraph. Okay, so contrast sensitivity, right? So there's a standard, you can get it, which is the Pell Robinson's is standard. And so it's a test that I don't really use as much because I don't have the right illumination in my office, and it is quite expensive. So the alternative I use is Berkeley Contrast Squares Test Sensitivity app, and that's free. And you can just download it. And what's great about that is that it will spit out what level they're at. So contrast sensitivity is 2 and above. And so what the Berkeley Contrast Square is, it's this flashing square that continuously gets lighter and lighter and lighter, and the patient just taps where they see it, and that kind of helps. Leah numbers, which is at my work right now, they are just flip cards of things that are were some numbers and letters that get lighter and lighter and lighter, and then the lightest ones they can read, you can see if it correlates to normal contrast sensitivity. So things like edges, things like contrast colors for edges, tables, and walls can help for compensations. That helps for beginning and end of objects. So people who Like they tend to trip over a shower lip because it's all white, or they're bumping into a doorway because it's white. Yeah, I know. I'm sorry. I know you can't see me right now. I have to try to plug in my phone. So there's unfortunately my phone is running low. Um, and when I do that, it does this weird thing. Hold on. I will let me sorry. Okay. Um, so the other thing for contrast sensitivity is that you want to increase light, right? So basically what contrast sensitivity is that it's the inability here, let's see, the inability to see details. It's very closely tied to the acuity. So being able to focus. So let's see if I can get myself. Here we go. Okay. Okay, I'm back. Sorry. And so you want to make sure that it's not causing glare. Glare is very can be actually debilitating and make things harder for the individual to see. So you want to make sure that you're having the light coming from behind or from the side, and that usually is the best. Okay, so field of vision, right? So you close one eye, and then you're going to be asking them how far they can see over here, up here, and down here. And so what I usually like to do is I do peripheral vision and field of vision at the same time. So I'll ask to hold like fingers I'm holding up, and they can see and they can tell me. And then you do it for the other eyes. But it is best assessed by optometrists because they have an ophthalmologist as they have the equipment. So certain things, I'm going to go through this. So what's good about this is that you have some protocols here and the research documents behind this. So I'm not going to go through each of this detail because I do want to get to the diplopia, which is the question that a lot of people have. And so the field of vision, basically what to retrain field of vision, there is like they say 30% after 6 months can regain field of vision if sometimes statistically when it comes to things like stroke in particular. And so basically with the field of vision is you want to have a red light in the field of vision that is affected. Um, they have done research and it's red light only, no other kind of light will do this. And particularly the best is light and sound, because again, like we say, there's like light vision is not isolated. So there is this parietal temporal portion of the sound that feeds into vision as well. So basically, if you put red light in and sound in the area of where the field of vision is lost, sometimes that can help regain some of the field of vision. And if not, people then just will still learn, even if they can't see in a certain part of area, that something is there. I have this machine called a Dynavision at work, and I do this with them. And the Dynavision is basically this big black screen full of red dots that turn on, and I turn it on and sum them into their field of vision where they can't see. And then they're like, I can't see anything. And I say, please, where do you think something is? And I'll tell you 90% of the time, they'll put their hand up where the red light is, even though I can look that they're looking straight ahead and they're not cheating. So that's basically what these are all kind of protocols and things that you can look up for field of vision retraining. Okay, so peripheral vision, right? We talked about like how you do it, cover the eye up and then have the letters, fingers up. And then sometimes I can just say like, I would put like letters as well to have them to read it to see if they can see it as sharp. And so what's good about this peripheral vision exercise is it works on fixation and peripheral vision. So you can pick 2 4 corners of anything. And so it would be, and sometimes I just put like sticky notes and I'll have them do that. Otherwise, it could be anywhere. They could be like, pick 4 corners of anything. And so you'd look at, say, if corner 1, as you're looking at corner 1, you want to try to see what's over to your right, upper right, as you're looking at 1, right? And then when you look at corner 2, you're trying to see directly below the corner 2. And then you look at corner 3, you try to see to the left of corner 3. And you pick corner 4, you try to see above, which should be your first corner. Using your peripheral vision, you look directly at corner 1 again, you try to see corner 4, which is directly below. You look at corner 4, you try to see corner 3, which is to your right. You look directly to corner 3, you try to see corner 2 with your peripheral up above. Look at corner 2, you try to see the corner 1 with your peripheral vision, which is to your left. Okay, so this is what a good picture of what peripheral vision is, right? Sometimes this is also an exercise I would give. I put an X in the middle and I tell people just to continue to draw it, and they're looking straight ahead and trying to use their peripheral vision. This is also a good one where they look, and I want people to try this. I don't know how big your screen is, but look at the X in the center. And as you're looking at the X in the center, your objective is to keep your eyes on the X, still seeing that clear, but reading all the letters around the X without shifting your eyes, right? And so when you do this, this is more like 16 it's where reading distance would be, so about 16 inches away, right? And so by doing this, you're able to help see where the person's peripheral issues are, because we think of peripheral vision issues as way out here or way down here, but sometimes it could be in the areas that are closer in than we realize for that person, and that they're missing it, right? And so things like central peripheral vision is important for things like walking, for things like driving, right? Because we need to use those sensory systems together in order to function. Okay, so this is some other exercises, right? For near far, right? You'd have the chart. So you see the sticky notes, right? I'm gonna try to show you, sorry. I'm gonna try to see if I can do this. This is gonna work. It might work. Okay. So I'm gonna show you this one. So you're gonna have a stick, broomstick, and this is where your central vision is. You're gonna be reading this out loud, letter by letter. And while they're looking at the central vision here, they're using their peripheral vision to hit the sticky notes. So it's going to be something like this. Oh, N, E, V, D, T, E, right? So what that does is it forces you to use the person's central vision, right? So they have to read clearly what they're looking at chart wise. And then their peripheral vision is locating where is it? Where is that sticky note? And it forces the two systems to work together. The scarf one would be the same thing with that heart chart, but this time you would just use scarves, no sticky notes with scarves. And the person would stand like this doing this. Because sometimes the person can get overwhelmed with any kind of, or startled. You'll have some people who are, if there's someone that walks in and they say like, oh, where did this person come from? That's a startled response. And I would get them to start doing that so they can desensitize themselves and know that, oh yeah, it's a scarf. If it hits me, it's okay. Just random circles. We'll skip this so I can get to, oh, that's a sticky note. Okay. Now, this is the important one that I wanted to get to. So diplopia, right? Monocular or binocular? So these are the questions I ask people. Does your double vision go away if you cover each eye? Oh, sorry. Um, sorry, I thought I plugged in my. Okay. Sorry. My phone's plugged in now. Sorry. Okay. So, does your double vision go away if you cover either eye, right? So that's how you would start to figure out if it's monocular. So monocular diplopia can happen when it comes from something like we talked about, something with the eyelid, not enough lubrication, or there's like a structural issue with the eye itself. So something like a wrinkle in the retina or something in the retina that's not right. And so things like going to see the optometrist is going to be important if it's monocular, right? If it's monocular, as therapists, we can't do anything about it, right? Okay. So what is diplopia? So basically, it is either when someone has two separate images, right? Or superimposed images or ghost-like image. And it resolves when you cover one eye and you cover one eye, right? So there's different alignments side by side, and there's also vertical. And so even if people say like there's a 45-degree, like a diagonal one, that's still a vertical diplopia. Okay. So other questions I ask people like, does it change in the day? When you're looking at something, does it seem like the objects are closer or farther at different distances, right? Um, and, you know, if you're tired, their diplopia might get worse, right? Um, and I think it's important to ask, like, is your diplopia better at different distances? Like, are the images closer? Because that helps me understand where there might have ability at a distance away from them to actually merge the two objects into one, right? So if the two images can get closer at a certain distance, I have the patient try to merge them, right? I don't want them to allow one to just disappear, because when that happens, that means the brain is ignoring information from one eye, right? And we want the brain to basically be able to see both eye information and integrate them, right? It's really important. So you have to remember that double vision is a central vision problem, right? It's not a peripheral vision problem. So what do we do? I don't like patching. Patching is very old school. It's the very last thing I'll do or recommend to do, right? Why? Because basically, if we patch, we're depriving the eye of light. And when we deprive the eye of light, we damage the rod and cones. We also we impair the peripheral fusion that can happen, right? And so basically, our central vision fuses, but our peripheral vision also fuses. And so, when our peripheral vision can fuse, it actually can help our central vision fuse as well. And so a lot of the neurooptometrists that I work with, when people are having trouble with central fusion or they're having trouble with double vision, the first thing they taught me to do is to try to fuse try to fuse their peripheral vision by doing certain things. And I'll show you, instead of patching, this is what we'll do. Okay, so spot patching, right? So spot patching is basically, okay, so instead of having a whole patch, what I tell people,
รูปไม่ได้ด้วย
the,
อุ๊ย
hello?
Please go ahead. That is not the question for you.
Oh, okay. And so what I have people do is have them put their glasses on, if they have glasses. If they don't have glasses, then I get them to just wear fashion glasses. So basically no prescription, but just glasses with like just lens. And then I tell them to look straight ahead. And if it's so first I have to figure out, is it a side by side or a vertical type of diplopia? So then I have them look straight ahead, and then I just keep putting my finger. So if it's a side by side, I just do this and keep asking them, do you see double? Do you see double? Do you see double? And when they say they see single, I take some tape and I just tape down that line. And if they have, I would prefer having two glasses, or I show them how to change the tape, because then I would do it to this side as well. Because I've just experienced that sometimes if you just try to, the classic thing is when you use patching, people want to patch the good eye so the bad eye has to work, right? I think the thing is that I like putting spot patches for both eyes, right? So you'd have a different glasses, right? And then you would do, say, this eye again. Do you see single? Do you see single? Do you see single? And as soon as they say yes, I tape it there. And so what's great about this is now people can see, and they're not seeing double all the time, but straight ahead. So they'd have to turn their head to keep seeing that single, but if they shift their eyes, they may have a probability of seeing double again, right? And so this is actually really powerful for people. I've had some people who are just feel like their balance is better, so and they can walk, because part of the double vision is that they can't see. There's two images, they don't know which one is the right one, right? And so this still helps them retain their peripheral vision. If you remember what peripheral vision is our where is it, right? So it helps them still retain where is everything around me, but then they are able to see one image, right? And then if it was like a vertical one, I would do the same thing. I would do this. Do you see single? Do you see single? right? Do you see single? And so that's why I prefer two separate glasses. So then I'd have one specific taped here, and then the other glass would be here, and then they could alternate days. And then sometimes if the spot patching doesn't work as well, say if they have something like a nystagmus, right? Usually this would work better where they have like a frosted lens like this. Also sometimes with like some severe cranial nerve palsies, like in this gentleman in the picture, putting on that frosted lens is going to help block out the double vision by diffusing what he's seeing. So he's still seeing the light is still coming in as well. He's still using his peripheral vision, but he's not seeing double, right? Okay, does that, right now I want to ask, does that answer some of the questions you were having about double vision, how to treat it, and also things like one of the questions was like, how do you help someone who has double vision in walking? Anybody?
Question again, please.
The question is, I got some pre-questions about double vision and walking and how to help treat that, and also just double vision in general. Does that answer, is there any more questions about double vision? Or did that help answer those questions?
สันมีอะไรจะพูดไหมคะ
Thank you very much ขอบคุณครับอาจารย์ครับก็ all the questions that come from the participant who register so thank you very much for the answer
Okay.
or
Okay.
maybe the participant can ask in online or type the question in the chat box.
Okay. So I see it's already 7 o'clock and we are we have I have already, I think it goes up to 150 slides. And so I think what we'll do is that's how you would work on getting someone's ocular motor skills as a basis to help them collect the information that they need as a person to be able to participate and in their daily activities and in their rehab. Vision is very underrated, and I think this is a good help. I did also put a link for on this for other ideas for eye exercises. I know I gave you some, but there's not all inclusive. So these are links that you'd be able to click on your PowerPoint and it'll lead you to it. And so the next would be moving up the visual hierarchy and visual perceptual skills and assessment and treatment. And so that is where we talk about things like now that your brain has told your eyes how to move and how to gather the information and bring it to your brain. And now it's like, what does your brain do with it? That's what the visual perceptual skills and assessment treatment part will be. And I think that will be for another time.
Okay, thank you very much, Roseanne. I think you are coming to Bangkok, so we can talk more on this topic surely later because it's very underrated topics for our patient care. Very
Yeah.
beneficial.
Yeah, and I think so I think it would be great if that before I come to Bangkok is that you whoever is attending, they can practice some of the things that I just talked about. Start practicing it with each other, with like your coworkers, start practicing it with patients. Like none of these things that you're going to do are going to hurt your patients. It's just practicing. And then so when I get there, it'll be easier. We can continue the presentations, the rest of this presentation, but we can also just definitely have some hands-on practice, and you can ask me questions about very specific visual things, because I'll be able to answer them.
Yes, yes, we will emphasize that. Physical therapist ทุกท่านคะ please do some hands-on practice ฝึกกับเพื่อนหรือคนไข้ ก่อนที่เขาจะมา consulting visit ปลายปีนี้นะคะ ฝากด้วยนะคะ จะได้มีคำถามมา discuss เพิ่มเติมสำหรับ2 Okay, already talk to them in Thai regarding hands-on practice before your chapter 2 in Bangkok. Yeah, thank you very much for today. It's very tiring for you in the midst of your illness.
I'm fine. Thank you for I'm
Can I ask one question?
yes.
Can all these practices can we use with the elderly without any neurological problem?
You could you could assess them to see if they have any ocular motor issues. I mean, if they do have some ocular motor issues, you could treat that. As we all get older, our contrast sensitivity will decrease naturally. So that's something that you could, at least implement. The tricky thing that and it's not just for the elderly. I mean, I think for everyone is that no one assessed the things that I just taught you. And so there's not really a baseline, right? So it's hard to figure out, like, is this something that can be remediated, or is this something that's like a long life issue, like they've had this since their childhood, and then it may not be something that they would choose to work on too. So there's, like, me being an occupational therapist, I ask people, sometimes people have problems historically, having problems reading their whole life, and they're having some more problems now, and I ask them, I'm like, do you want to get back to where you were before, your baseline, or do you want to try to work where you were, you can get better than you were before? So I mean, you can use this with the elderly. I just think most of these exercises and treatment, you just want to make sure there's no like historical visual issues that would be hard for them to remediate. Does that make sense?
Yes, thank you.
Thank you. Thank you once again, and we hope you get well soonest, Roseanne. See you next time.
Okay, thank you.
Yeah, thank you very much.
Thank you very much.
Many questions waiting for you when you come here.
Okay. Yes. It's easier in person for sure. This type of presentation, because and demonstrations of things. Hands-on is the best way to learn for this type of stuff.
Okay, now it's time. Thank you. It's a very new difficult issues today. And thank you very much.
Thank you all for being patient. With my technical problems and me being ill, I'm sorry. Thank you so much.
ตันมีอะไรอีกไหมตัน
ครับไม่มีแล้วครับขอบคุณทุกคนครับ that all the participants today really a lot more than 140 it's really appreciate that you all have a new student today too great for us you
Okay.
take care
Yeah,
real
and
soon
yeah, and
Yep.
so if you have questions, write them down and then keep, if you notice, what I encourage people to do is that if you think, it's easy to be like, oh, something, if someone says they have double vision or if they have a field cut, it's easy to try to assess their vision. But like the one of the first slides of, if they say that they're having vision issues or they have some issues that are, in a different part of the brain, sometimes that can manifest as visual issues. So sometimes I always do a quick visual screen on my patients just to kind of make sure that some of it's working well. And if it's working well, great. If it's not, then that's where I can help them heal. Because you have to think the brain, like it is a whole entity. So if we can address vision, that will help save someone who has a stroke, save enough energy so then they can be able to walk or see right when they're walking or see when they're and not bumping into things when they're walking, right? Like depth perception is important for things like stairs and curbs and uneven ground. So I encourage you to try this just to see how it feels. And you have all the resources. Okay, it is a pleasure. I will
Excuse
see
me
you.
one question that the term that you will in Thailand on November right
Yeah, right now we are, that is the projected time, but we are not sure at this moment.
yeah
We're trying to figure all those things out. We'll know more by the end of this month.
okay yeah right maybe after you know the duration already we will discuss about the schedule that the class will set together to sharing for the BDMS physical therapist and occupational therapist
Yes,
yeah
yes. So yeah, it'll probably be Dr. Denny who will be able to kind of help figure those things out. We'll know by then. But still, regardless of if it's November or not, I'm glad that you all have the tools now to try. There's a lot of resources that I gave you. Try not to be overwhelmed. I'm sorry, but it's just good that you have it. So then at least you can use it. You can share it with others. Because the thing is that I just want everybody to be able to help people as much as possible. I mean, I will say that I, have been doing vision for now over 10 years. But before, and I've been working as a therapist for 21 years, but the 11 years before, I was probably not, I didn't really use vision or didn't vision that much. And now that I use it, I see how it impacts the person's ability to function, reaching for things, walking, that type of thing.
I saw from the chat that there's one question from the I don't know TT or OT. Why we need inhale and exhale synchronize with eye movement? Why we do eye yoga?
Okay, I see that. Good. So why we do that is we want to inhale and exhale because what can happen is that when people tend to, after some neurological condition, they move their eyes, it causes symptoms like dizziness, headache, eye strain, nausea. So they tend to hold their breath subconsciously. And so when we do the eye yoga, the part of it is to kind of think about inhaling into the muscle, relaxing and trying to kind of reprogram the person to move their eyes and breathe, because they're not breathing while they're moving their eyes. And then when they're doing that, it's causing them more symptoms and more pain. So, and it's also a very relaxing thing to do when we're doing inhale and exhale. So we're calming down our system. So we're actually, you know, I think of it more like diaphragmatic breathing. So diaphragmatic breathing, you know, we've got the vagus nerve, and then the vagal nerve, right? Starts here, passes down to your diaphragm, and then connects to all your organs. So when you take an inhale, hold it, your diaphragm, it basically, so your diaphragm is like a bowl, right? And so when you inhale, push it up, and then when you exhale, push it down. And so what it does is it turns on your vagus nerve, which is a physiological reaction to help relax the body and your whole system. So it is just, those are the reason why that you would do something, why you would be using inhale and exhale for that.
So thank you for answering the question. I think now it's time for us to go back to work.
Yeah, I think so too.
Thank you so much, and looking forward to seeing you in Thailand.
Yes.
Thank you. Feel better soon.
Oh, yes. Thank you. I hope so.